Firstly, thank you all for joining for today's community meetup of this month, February 2026. We'll start the agenda or the flow for the session we'll start with the ecosystem update, wherein we will walk you through the new NGOs that has come on board with Avni and the project that has gone live. Then we have Dr. Devanshi from the PHRII team who will be talking with, sharing with us about the insights and about the importance of early cancer screening. So she will be sharing her experience and insights. And obviously, let's keep this session interactive. If you have any questions about cancer screening, about cancer at Genvic, please feel free to ask Dr. Devanshi. We have the expert with us today. And then Maha will be sharing about the product updates, so whatever latest development has happened in product, and in terms of the updates that has been happening. Yeah. Yeah. So starting with the ecosystem updates, Animate Charitable Trust, ATC, they went live with its Nanhe Kadam program last month. So ATC has been associated with Avni and have been using the Avni product for their multiple programs. So before Nanhe Kadam, they have also been using Avni for their MCH program. So Nanhe Kadam, so it's basically it focuses on early childhood development for the child age group between 0 to 6. ACT, Anime Charitable Trust, as an organization, they work to act and make difference by supporting underdeserved children, youth, women, and individuals in the vulnerable community. So who are lacking in terms of education, livelihood, and basic opportunities. ACT provide them with that support. Till date, they have worked and has helped over 9,000 children, 71,000 women, and have reached more than 384,000 people in their community. Talking about the Nanhi Kadam program, as I mentioned, they focus on development of children between the age group of 0 to 9 years. They primarily focus in strengthening and caregiving, basically early detection of if there is any developmental delay or risk, and providing them with the support so that the child can come up with those milestones and achieve the milestones. They went live with Avni for tracking this intervention in the month of towards the end of January. Not sure if anyone from Animate Hina joined. Maybe I can just quickly check. Yeah, I think Hina couldn't join. Okay, no worries. We'll move to the second. Okay. The new NGOs which has come on board and have joined the Avni community has been Sangwari, Monkey Sports, JK Lakshmi, Cement, and Astitva. So Sangwari, they are into your health and nutrition program, and they do intervention in the Surgarh district of Chhattisgarh. Monkey Sports, they work in the no mental health and physical well-being of children. They do after school sessions for no physical physical stress sports sessions and all to help them with their physical activity and for their mental well-being. JK Lakshmi Cement also we have partnered with them, and they're planning to use the Avni application for their Nya Savera program, which is into maternal child. And not sure if Pooja has joined. Pooja, one of our consultant, she's there right now on field, working with them in their UAT process. Pooja, have you joined? Let me just check.
Yes, Anjali, I've
Yeah,
joined.
Pooja,
I've joined the meeting. Yes.
if you can share your experience and a little bit about how it's been there.
Yeah, it is a really whole new process for me to go here, like on the field and start working with the field users, even with the main character who works here as a CSR on the JK Lakshmi. It's completely whole experience, as I'm saying, since we are sitting here, so we know what exactly the issue they are facing, and we can just add according to their requirement if it is possible on the spot, which make them more happy, like that. So yeah, that experience is really good, and we should experience this more, do this experience in more.
So
Neeraj is also there, but yeah,
go ahead,
he's
sorry, go
listening.
ahead. No, continue,
Yeah,
go ahead.
right now. So today only I have done one field visit. So they have some doubt So I'm trying to solve it and everything. Like, yeah, it's a good process to be done. Yeah, that's
Thanks, Pooja. I hope you are like it's a completely new experience and are gathering all the information on there. I think this is one initiative we started to make our process more smooth and not to even more for our team also to understand our clients better. So our consultant have been traveling to the client location during the UAT phase so that no they can understand if there's any issue they are facing and to make the process more effective and streamlined. Besides JK Lakshmi, Astitva is another organization. They are based out of Nilgiris OT, and we have started we have started the development process for them as well. They work in nutrition initiative for tribal children and mothers. Yeah, so they have education as well as health. So currently with Avni, they want to go ahead with the health program and then eventually move to the Nourish, which is a sorry with the health program as well. So besides that, after the success we have seen with cohort one, which happened last year, with around 10 NGOs participating and no, they doing their pilot, and then out of them, most of them now coming into and building a long-term relationship with us. We have started the cohort two from this month. We have done the orientation on 6th, and now the scoping and the process is beginning. These are the organization Bal Kalyan Sanghh, Maji Saheli Charitable Trust, Deep Shikha, Khyamta Aman Foundation, Viva, and Neev Ki the other organizations who are participating in cohort two. I think we have Nirati from cohort one. Nirati, would you like to share one or two words about your experience in cohort one and how now with the pilot and everything it has gone? Just few thoughts if you'd like to share. Nirati, would you be liking to share?
Yes, hi.
Ha, ha.
Yeah, yeah, yeah. Yes. Yeah, so it was a really, it was a very good experience in cohort one. Initially, when it was through this, the support that Avni team provided me with in making the app was really very helpful. And मतलब सबसे ज्यादा तो it was initially when the cohort happened, the meetup happened for 2 days. So then I could really start framing the app. I could understand how the work will, the workflow. I could understand the workflow, the data collection techniques, and you know, because we are working with the farmers for this Avni thing. So it was our priority. The data collection and management was a priority, and the team helped us out in everything, like the coding parts also, basic conditionings and everything. So it has really helped us a lot in that, in the framework of the app. And it was very easy. I did not feel, initially I was a bit skeptical that I've never like coded something or made an app or something like that, but it was very easy with the team and everything, with the support. And we also did the pilot in January, and the team, like the field workers, were also very it was very easy for them to use the app. The app was really it was very friendly for the field workers also. So I did not have to explain a lot of things and train them a lot of things to use the app. So that was also a very good part of it. Like it is very user friendly.
Great. Thank you. I think that is really, I think as a feedback, really glad to hear that your field team on ground using Avni for the first time are finding it easy and effective for them.
Yes.
Yeah, yeah. As a flow, as a UI of the app, if they're finding it effective and easy to use, we are
Yeah,
really glad to hear that.
they were not very confused about using the app. They were very they like I told them once or twice only, and they were able to use everything from start to the end and feed the data accordingly. So that was really that was a positive response from the field that yes, we can go ahead with this.
Great, great. Thank you so much. Anyone have any question for Nirati or Pooja or the slides that we have gone through so far? Any questions? No? Okay. We'll move to the next. So today we have Dr. Devanshi from PHRI, who is going to have introduced this feature talk session in today's community meetup. As February 4th was the World Cancer Day, and we all know how cancer as a disease, it's been like it's something I think every one of us would like to know more. And so Dr. Devanshi, since he has been working in this area for so many years, we thought it would be a nice opportunity if she could share her insights and make us a little bit more aware of some of the myths or no some of the facts related to cancer screening. No, and for that we have Dr. Devanshi. She has so just a quick introduction about Devanshi, and then we'll pass it on to her. Dr. Devanshi is a US trained obstetrician gynecologist and a public health professional with over 20 years of clinical experience, and she has extensively worked in leadership in global health research. She serves as the program director of the Cervical Cancer Prevention Center at Mysore Constam against the cervical cancer, and she's also working as the director of the public health for PHRI. So her work mainly focuses on advancing the health, health quality and equity in the low research settings, and also emphasizing on importance of cervical cancer prevention in women health. I would pass it on to Dr. Devanshi. If you could, walk us through and share your thoughts about it. Yes. I will stop sharing. Would you like to share your screen?
Sure, I will. So just a few corrections, just a small minor correction. I don't direct the entire institute, just the cervical cancer screening program. Are you guys able to see my PowerPoint?
Yes, Devanshi.
Yes.
Okay, great, great. Okay, so like Anjali, thank you so much, Anjali and Avni, for giving us this opportunity to share our work, and very excited to be here. And I'm going to focus in. This is Cancer Prevention Day. February 4th is Cancer Prevention Day. This is the month for that. We are going to focus in on cervical cancer, which is the second highest contributor to mortality from cancer for women in India, the first being breast cancer. Most of our work focuses around this, so I'll hone in on this a little bit more during the talk. So, why is cervical cancer important? Well, let's look at some statistics, right? If you look at, well, this slide didn't come out exactly right, but the enteric infections, respiratory infections, and TB, these top three are the top leading contributors to mortality in 1990 versus cardiovascular disease and chronic respiratory disease and cancer is now, they are the top three leading to contributors to mortality in India as of 2019. So this is looking at a heat map. If you look at the global age standardized rate for cervical cancer, meaning per 1 lakh women in 2022, in the US, 2.2 women died of cervical cancer. In India, it is 11.2. And one woman dies from cervical cancer every 2 minutes, but in India, that number is one every 8 minutes. Not only does cervical cancer kill women, but it kills women young. So it is in the top three cancers in 98 out of the 185 countries in the world, which is about 52%. But if you look at women under 45 specifically, this is now 79% of 144 out of 185 countries. This is a graph that looks at mortality from from different types of cancers leading to maternal orphans, which means children under 18. So this second pink band over here is the band from cervical cancer. So global data for 2020 is that 341,000 women dying from cervical cancer, and there are 210,000 women, children who are orphaned by their mothers dying. So 2/3 of the death result in maternal orphans as well, which is the heartbreaking part about this cancer. And the high cancer death rates are because of poor screening rates. So if you look at this is a heat map of screening rates all over the world, and India is in the darkest red. Our screening rates are less than 2% when you compare that to other countries. Like US is 75%, we are at less than 2%. This is what we call a cartogram. So each country the size is dependent on the number of cases that they contribute to global cervical cancer. And if you see here, India is this big yellow balloon in the right half of the slide. 20 to 25% of new cases of cervical cancer every year come from India. Like I said, screening rates are very low for both breast and cervical cancer. Breast cancer screening rates are less than 1%, cervical cancer screening rates are less than 2%, and they're 75 to 80% in countries like the US or European countries. Lifetime risk of dying from cervical cancer is 1 in 53 for Indians. There are over 127,000 new cases and almost 80,000 deaths that happen in India every year. And the problem is because there are several challenges to screening. One is we have 47 crore eligible women to screen. That's a big number. That's entire countries put together. And for vaccination, there are 7.2 crore eligible girls. So there's both a vaccine available to prevent from getting the virus that causes infection, and we'll get into that in a little bit, and 47 crore women that need screening. Current coverage is low. Like I said, the mortality is among young mothers, so it hits us especially hard. And barriers to both screening and vaccination is one is access, second is cost, lack of awareness is one of the biggest bottlenecks, stigma, and screening requires pelvic exam if you use the cheapest form of screening. And Indian women, not unlike a lot of other women, don't like pelvic exams. And the last thing is that once somebody screens positive, nobody knows what to do. And that's another barrier for cervical cancer, for combating cervical cancer. There is a roadmap outlined by the WHO to solve this problem. It says that 90% of girls between 9 and 14 should get vaccinated with the HPV vaccine. So when you have children 9 and older, you should definitely consider the vaccine. 70% of women should get screened before once at 35, once at 45 at bare minimum. And 90% of the women who screen and are identified as being as precancerous or cancerous should be treated. And if you look at why we should do both versus just doing one or the other, if you look at this blue curve here, if we were to vaccinate, so let's say our mortality is 14 per 1 lakh, and we just vaccinated. To come to this halfway point over here, it takes about 50 years. But if you screen and vaccinate, we can achieve that same halfway point in about 15 years. And that's this purple graph over here to the left of the screen. So that is the difference between doing one or doing both. And it is worth its weight in gold. Every rupee we spent, this is a WHO study, so it is analysis, so it's in dollars, but every dollar we spent on cervical cancer screening has a threefold return on just keeping women healthy and keeping them in the workforce or supporting their family who are in the workforce. If you add up how women help their families and their communities, that ROI goes up to 26 times. And if we are able to implement this properly, just by 2050, we can keep 250,000 additional women healthy and working, add $700 million to the economy and $27 billion in health savings alone. So basics about cervical cancer, it is caused by a virus, which is very, very common. Out of everybody at this meeting, 70 to 80% will have this at some point in our lives. And at any given time, at this minute, about 5 to 8% of us will be positive. And it is one of the few preventable cancers and the only 100% preventable cancer. So when we go into communities, people don't understand what cancer is. And a lot of you nonprofits out there have the same challenge of first, helping your beneficiary understand that there is a problem that they can solve. So when you talk about cancer prevention, it's very hard to explain to somebody what cancer is. And this is sort of an example we use in our educational materials, that every woman buys tomatoes, right? And then 4-5 days later, some tomatoes will develop these black spots. And so we ask the women, what do you do when you develop these black spots? And they tell us, we cut them off and the tomato is still good. Then we tell them what happens when you don't do that. So you let the tomato sit there for 3 or 4 more days. Then it becomes this rotten tomato on the right side. So we tell people that cancer screening is very important because it helps us, just like saving your tomato, it helps to save your life. Where if we catch you in the early stages, in the early cancer, pre-cancer or late pre-cancer stage even, we can save the tomato completely. No symptoms are there at this point. So you will not know that this is going on. That's why it's important to screen. But treatment is a simple 2-minute procedure that doesn't cost much at all. But if you wait and this develops into cancer, now you're talking about surgery, chemotherapy, radiation. So we all struggle with coming up with examples and educational materials in our catchment areas of how to explain the benefits of our program. And this is how we came up with ours. There are three different places to prevent cervical cancer. One is primary prevention with vaccination. And we'll talk about what the vaccination schedule is in a bit. That you administer in 9 to 14-year-old adolescents. If you can do boys and girls, that's fine. It is fine to administer even up to age 26. Beyond 26, the benefit sort of goes down. At that point, screening plays a more important role. This is secondary prevention, where you screen for the virus. If it is there, you treat it and you prevent it from developing cancer. And tertiary prevention is once somebody has already developed cancer, then you treat them at an earlier stage as effectively as possible to save their life. So cervical cancer prevention can be undertaken with both screening and vaccination. And so if you screen alone, if you just do a one-time screening, right, you will save 5.7 lakh deaths, which is, right away, but this is a green curve here. Vaccination benefit comes a little bit later, right? So if you vaccinate children, then the death, you will save about 6.4 lakh deaths, and they'll come a little bit later. But combined screening and vaccination, 12 lakh deaths can be averted. So these are the different screening methods that are available in India currently. One is VIA, where you have to go for a pelvic exam and they look at the cervix after putting some acetic acid or very dilute vinegar, and they're able to see if there's something precancerous or not. Most urban people who are educated usually go to the gynecologist and get their pap smear. And then lately, for the last 5-10 years in India, there has been this HPV DNA test, which is very simple. It is done with a Q-tip, and it only needs to be done twice in your lifetime. Whereas all these other tests need to be done every 3 years. So that's why this is the preferred test by WHO, and it is also considered the most cost-effective test. Why is India's screening rate under 2%? Why are we not able to do this? Well, because the other two more commonly used tests are pelvic exam based, where somebody has to take their clothes off, go in front of a doctor, the doctor puts an instrument in. Most people don't like that. And then also there are not enough providers that know how to take care of patients and how to screen properly. There's a lot of stigma in the communities for people who have cancer. They feel like it's a death sentence. You cannot be saved, although it's very far from the truth. And there is high cost associated with screening, but less than what it costs a country or a community if the same women develop cancer later down the road. These are the screening recommendations by both FOXI and WHO. Start at 25, says FOXI, which is the Indian authority, 30, which is what WHO prefers. Both prefer the HPV test, but FOXI says do whatever is available to you, which I also agree with. Pap smear, VIA, anything is fine as long as you get something done. But HPV test is the preferred test, and it should be done every 3 to 5 years. And pregnant women can also screen. Menstruation is not a contraindication to screening. For vaccination, again, the Indian authorities, for both, girls are a higher priority because most HPV-associated diseases, that is cervical cancer, occur in women in women. So girls are a better target to go after as a first target group. But eventually, girls and boys will both need to be vaccinated. Boys can get HPV-related cancers as well. FOXI recommends 2 doses. WHO says even 1 dose is good enough. The immunity is almost just as good. For 15 to 20-year-olds, 3 doses for FOXI, 1 or 2 per WHO. And anybody older than 21 is 3 doses per FOXI and 2 doses per WHO. So these are the different ways to prevent cervical cancer. At age 9 plus, you get vaccinated. In your 20s, you consider vaccination, but also start thinking about screening. In your 30s, 40s, and 50s, you focus mostly on screening until your 60s. This is the work that just a little bit of focus shift towards what we have been doing. We are based out of Mysore. We're called the Public Health Research Institute of India. And we work on both research and service delivery. But during our service delivery, also try to teach other providers and work towards capacity building. And we also try to have quality discussions with policymakers to change the national landscape, or at least a statewide landscape, for cervical cancer screening. This is what we have been doing since 2009, starting with education and awareness. We also started with the very rudimentary VIA, moving all the way to HPV-based screening, and most recently, we're doing self-collection. And we'll show you a video about what self-collection is. And so we also work with a community to find solutions that they have high buy-in to. We go and observe communities, we try and understand their viewpoints, and then build interventions that kind of cater to their needs as best as we can. This is a hub and spoke model where we have a cervical cancer center where we do a lot of the technical work, but all the patient interaction happens in the villages, where we identify patients, train ASHA workers, do the self-collection, and then we bring the samples back to our center to run results. And then again, we go back into the community. So a lot of our work is community-driven. And this is just a brief video on self-collection and how it works. I'll just play it quickly, just parts of it. Oops, what happened? Can everybody hear?
I think the volume needs to be.
To a new self-collection test.
Yeah, now.
This test checks for an HPV infection or human papillomavirus, which can cause cervical cancer. Protect your health, protect your future. Test for HPV. It's okay to feel nervous. HPV self-collection test is a safe and effective way to help protect yourself from cervical cancer. This test checks for an HPV infection or human papillomavirus, which can cause cervical cancer. If you need help, just ask your healthcare provider. They can guide you without invading your privacy. And if you make a mistake, don't worry at all. Just ask for a new swab and try again. Before you start, wash your hands with soap and water or use hand sanitizer. This is a self-collection swab. Yours should have one end for you to hold and a soft tip for collecting the sample. In a private space, remove your underwear. Now find a position that feels comfortable. You can sit, stand, or squat, whatever works best for you. Take the self-collection swab and twist the cap to open it. Always hold it by the cap and don't keep it down. The swab should be gently inserted into the vagina. This is the same place where you get your period, where sexual intercourse happens, and where babies are born from. If you drop it or it touches something, ask for a new one. You'll see a marking with a red line on the swab. This shows how far to insert it. Gently place the swab into your vagina, stopping at the marking. Rotate it slowly 15 times.
Okay, we'll stop there. I think that gives you a rough idea of.
Simple and easy this is. These are similar videos for vaccination as well. Then there are QR codes there. I'll come back to the screen eventually. So the question is, we can't take, one broad brush and paint India and cover cervical cancer screening. There are a lot of women that need to be screened and a lot of adolescents that need to be vaccinated. I think what we can do is come up with our own individual bubbles, and that applies to anything that we do in India, any non-profit work, whether it's education, WASH, health, whatever, right? We all start our own little bubble, and then all these bubbles sort of grow and come together, and sort of it coalesces into impact countrywide. So that's a little bit about the work that we do. And if anybody has any questions, I'm happy to answer. I'll actually take it back to that slide in case somebody wants the vaccination education videos.
Thank you, Devanshi. I think this was like so much information I was not aware regarding the. I hope, yeah. Anybody, any question, please feel free to ask. Let's get all the information from all. Any questions?
This was very informative. None from my side.
Anything from anybody, please feel free to ask.
You can always contact us at, we can go to our website. All our contact information is there, www.phri.com. If something comes up later, we do a lot of community-based participatory research and we get community input into building our intervention. So if anybody wants to talk to us about that at a later point, feel free to reach out to us.
Absolutely. I have a few questions, Devanshi. Firstly, in terms of getting the screening, so vaccination, I think, is something based on the age we all should get, irrespective of like how we get our flu vaccine and all. What about the
Exactly.
screening? Screening, do you think only we do when we see some symptoms and then we do the screening, or it should be a part of our regular health checkup, which we do?
So if you look at that slide, right, that compares this to the tomato, right, over here in the first 3 stages where you are first getting the virus and you have early pre-cancer or late pre-cancer, right, which is when the 2-minute procedure will work. There
Correct.
are no symptoms at this point, zero. You are going about your life, everything feels fine. It's like the tomato where until you lift up that tomato and look at it, you're not going to see the black spots. There's no smell coming, there is nothing rotting, the tomato has not shriveled, there is no juice coming out of the tomato. Everything feels fine until you pick up the tomato and look at it. So very similarly, in the early stages, there are no symptoms. By the time there are symptoms, it is very difficult to save, to save somebody's life from cervical cancer. At that point, if we catch it in the early stages of cancer, still 20 to 40% of women die. And unfortunately, 80% of women are diagnosed in stage 3 or 4. At which point only 20% of women are able to be saved. So if you wait till you have symptoms, it's too late.
So we get it done as a regular health checkup procedure with me.
Right. We tell patients, like you have a two-wheeler, you take it for servicing, you take it for maintenance.
Correct.
Similarly, our body also needs service and maintenance. We are the engines of our family. And our service maintenance is check for cervical cancer every 5 years. After the age of 50, start breast cancer screening every 2 years. Check your BP every 2 or 3 years. Check your sugar every 2 or 3 years. This is the bare minimum maintenance our engine needs. And this is what we should be doing.
Got it. Yeah. I think this is something we all should make it a habit of our regular training. Yes.
We put more effort into our two-wheelers than we do for ourselves, which is sad.
Agreed. Totally. What about in terms of the community or the area where you work in? There's a lot of like cancer as a word itself is very traumatizing, and people usually hesitate to talk about it or get it screened, or no, usually they ignore it unless it's like a very severe thing. In your community, how do you as an organization and your team try to break those stigma and make people ensure that they are doing their screening? Do you do some like how do you?
So Kiran, who's the head of our community outreach, is on here. Kiran, do you want to chime in on that?
Hi everyone. Sorry, okay, I can put my video on briefly. Yeah, I think stigma is a huge challenge, and a lot of that comes with either not knowing enough information about this or misinterpreting the information about this. And how we break stigmas, how we provide them with the information about this. So there is a lot of things we test, right? We test products in cosmetics before it's put in the market. We test tech products that go into the market. We test extensively. We test drugs and devices that go into medical care. But what we don't test enough is messaging, and that is just as important to get people to take their health seriously. And how we say things can be interpreted to different people in different ways. We mostly work within low literate populations here in our rural, tribal, and peri-urban regions of Mysore. And then we have learned over time, some of them have been received not so well. So we learn with that. But the best way to learn is research and testing, I think, and to use different methods to test this, because what works in a hospital setting will not work in a community setting. So we use a lot of qualitative research, a lot of focus groups involving different stakeholders in the community, and ask them, this is how we want to talk about this problem. What do you think is acceptable in your community? Do you think people would take it seriously? What are the issues that might be there if we do put this message out in your community? How do you interpret this? What do you understand by this? So yeah, a lot of extensive research is needed within this, and using innovative ways of research. So the traditional just collecting a survey is not enough. We have to sit and have in-depth conversations with people.
Thank you,
But
Kiran.
it must be impacting on their emotional quotient also, no? If somebody is detected, so you need to handle, like, take care of that part as well.
Right, right. Yeah, no, that's why Kiran is also working on a project that involves a lot of men in the conversation, right? Because in our communities, for anything, an individual does not make a decision. Peer support and
Correct.
family support are also very important. And Kiran is currently working on a project that brings men as part of this conversation for cancer prevention in women, because without this support, there is limited penetration for any of these interventions.
Agreed. True. Yeah. Anyone from the participants have any questions?
Thank you so much for giving us this opportunity. Go ahead.
Yeah, I
Sorry,
think
Sandeep.
Arjun has a
Yeah.
question.
Hi, Devanshi. One basic
Hi,
question.
Arjun.
I mean, this vaccination is not part of the country's vaccination program, is it? And if not, why not? If it is
So it
so
is
simple and
recommended by the
important.
country. It is recommended by national authorities. NTAGI has recommended it. FOXI, which is the Indian OB-GYN Society, and the Indian Pediatric Societies all recommended. It is not part of the UIP. UIP is government will pay for it. And the reason it doesn't pay for it is because the MRP of the cheapest vaccine is 2,000 rupees. And there are 7.2 crore girls that need to be vaccinated, and 1.2 crore girls get added to that cohort every year. But it is, it is working on a budget where it will be included in the UIP, and we think in the next 2 to 4 years that will be the case.
Sorry, so I'm not, if you can put it in context, like this, you're saying 2000 rupees. Let's say we get a lot of other vaccines done for, especially from new birth and so on and all of that. Like, where does this fare in terms of cost?
It is
And
expensive. It is
okay.
expensive compared to a few hundred rupees. And then all the rural populations, all those other vaccines, when they're part of the UIP, they're completely covered by the government. This is not.
No, that's what I mean, because they purchase in bulk, and what we've seen is that when we go for private and various vaccination, even like our newborns vaccination would cost somewhere around 6,000, 8,000 rupees and all of that as such. So it's not like, it doesn't feel like, I mean, this rate you're quoting is what government will get, or is this like
The
a private?
2,000 is the MRP for that the company sells it to the physicians. The physicians will probably do a markup and give it to you for 3 or 4,000. And then depending on what the age of your child is, at minimum you need 1 dose, or you need 2 or 3 doses, right? So it is 2,000, 3,000 rupees times 3 doses. So then that becomes a 10,000 rupee investment and urban people like us will be able to afford it, but rural populations are not, which is why even though the vaccine authority does recommend to get the vaccine, it approves of the vaccine, and all the academic authorities, both for OB-GYN and pediatricians, both of them recommend the vaccine, but it is not. UIP means it is fully covered by the government in people who want to get it, and that it is not a part of that yet.
No, I was talking of the UIP only because I think totally understandable the on-pocket expenditure for individuals as such. And then, I mean, this seems like a public health problem, so why not take it at that level, really?
I mean, the
From
answer
what
we
I've
get. Go ahead,
From
Raghavi.
what I've heard is, like, if there is a negotiation going on between Serum Institute of India and Government of India. So regarding this cost, I think Government of India wants to procure it around 250 rupees or something. But Serum
Okay.
Institute of India is quoting a higher price.
Okay.
So
Okay.
that
Makes
is where
sense.
the negotiations are stuck, and probably they are trying to, via media, discuss something. So because
Okay. Makes
for
sense.
minimum cost they have is 1,200 something, and Government of India wants at 250 or something. So that is where it's been stuck for past 1 year, I think.
Okay,
Thank you,
so that
Raghavi.
makes sense. Yeah, thanks a lot.
Yeah.
Also, one question, so for an individual who is, say, in her 20s or 30s, who is getting her regular health checkup and HPV checkup done, and that is coming normal, do you think like for them also it's advisable to get the vaccine, even if they're doing a regular health checkup?
So I think, yes, once somebody is in a stable relationship, married, and past their 9 to 20 sort of age, this thing, they should focus more on screening. That at that point, after that, it becomes an individual conversation we have with a woman. When I was 35 when I got my vaccine, and now 52. So I did choose to get the vaccine, but I had to pay for it, right? So, and which I didn't mind, as I felt like if, so I did choose to get the vaccine. My child was vaccinated when he was 9 or 10, and he was a boy, and he did get vaccinated as well. But if for people who can afford it, sure, get vaccinated. Boys and I mean, men and women both can get vaccinated. But if you're looking at it from a public health perspective, the biggest return on investment is for 9 to 14-year-old girls.
Got it. Thank you, Devanshi, so much. Any more questions for her as we'll move to the product slides?
Let me stop sharing.
Okay, yeah. Yeah, over to you, Maha. You want to share your screen?
Sure.
Yeah.
So am I audible? And my screen is visible, right?
Yes, Maha, yeah.
So on the product side, we are working on a set of features. So one is ability to navigate to beneficiaries' home. So capture the beneficiary's location and being able to navigate to their beneficiary's home. And it was thanks to PHRII organization and Devanshi for helping to clarify the requirements and the problem statement that helped us to boil down to a particular solution that we think will solve the problem. So I think it would be released by today or tomorrow to beta testing, where it can be tried out. Next is ability to resume enrollment and visit forms with the draft saving. So what happens is currently already in Avni, we have this registration forms and encounter forms, visit forms that are not associated with program. If they are long, you can use the draft feature where it will be saved even though you have not purposely clicked the save. It is especially useful when some field worker gets a call in between, or when the field worker needs to do a set of tests and they can't complete all the tests that is needed to complete a form in the same time, etc. So again, this was funded by PHRII, and this as in the development is done and currently testing is going on for this feature. So the next feature is from RWB organization. We learned that when a user logs in, they are not able to figure out what to do next. So we have actually boiled down, figured out some of the approaches and shortlisted one of the approach where towards the end of the slide, I would like to receive inputs from this audience as well, from you all. And then next, for a production running smoothly, we are working on a set of upgrades related to on report side. So for reports, we are using basically two tools, Metabase and Superset, and we are working on upgrading both to the latest versions to utilize all the features that it provides in the latest versions. And then when it comes to migrations, the current database that we are using in mobile app has become deprecated. So we are working to see how to improve, upgrade the version or migrate to a different DB. So there were fewer migrations that we are working on because some of them, the companies who own it have stopped owning it, or some of the bugs that are long pending or not fixed. A few other features are some user-friendly CSV uploads for doing registration, and ability to resolve issues faster with logs. I think in the last community meetup, I showcased this. And then for someone who configures Avni app, would have known that bundle upload is a commonly used feature to go live. So the time taken for that has been reduced. So now we can dive down to a specific set of features. So I would like to showcase on how this works and how this feature can be used. So I'm currently in actual. Sorry, just a minute. I think I will just. So I am currently in actually Ghatkopar area, which is different from Andheri. So in Mumbai, there are two different areas. One is Ghatkopar and another is Andheri. There are many areas, but yeah, these are two different areas that are there. So in order to showcase this feature, I just mocked myself to be in Andheri. Currently, I'm in Ghatkopar, but I just changed the GPS location using a feature in the mobile to be in Andheri so that I can showcase the navigation feature. But I have just moved the location to be in Andheri to show the navigation feature. So basically, this is my location, which is near RJ Spice restaurant. Now let's move to Avni. So here the profile details of this individual has all been changed. So when I click on add location, it asks me for permissions and I give permission to just record the precise location. And it says that location is found with an accuracy of 5 meters and I click save. So location is saved and it is telling me to download offline maps to navigate without internet. So if you see, I don't have any internet connection currently switched on. And I have already downloaded offline maps for Mumbai. So now the location is recorded. So now when I click on navigate, it is taking me to Andheri. It is showing me Andheri. So suppose say so it has when on clicking of navigate, it has taken me to the recorded location near the RJ Spice restaurant. So suppose say I am on a different location as well. Just to show how it looks when I move to a different location, I am moving to Ghatkopar now. So basically, I have changed few settings to move back to the original location instead of the location that I did in my setting. So currently, my location is Ghatkopar, and say I have disabled the login location, and say when I click on navigate, it shows me near the RJ Spice, and I can click on directions to view the directions. So Google Maps in offline mode provides only car navigation. There are other apps like OSM and etc. which can be used to find out the walking directions as well. So now let's say the beneficiary has moved from Andheri to Ghatkopar and I want to update the location. So I can click the edit location and it has updated. So now when I navigate, it is showing me the Ghatkopar area, which is this is my current location that is recorded as well. Building number 100. And here when clicking navigate, I can. It also shows the beneficiary name on the top. The Aditya is the beneficiary name. It shows that and the like that. So now I can say the directions.
This is so exciting.
Okay. Thanks to know that, Devanshi. Any inputs or feedback you have on it, on how it can be improved or if it is different from what you expected or anyone else as well?
I think we'll have more feedback when we take it to the field in a few weeks. But the fact that this is able to work offline is just phenomenal. And the fact that you can edit somebody's location if they move, another great feature.
Sure, Devanshi. So I downloaded the offline maps before doing this. So that is a Google Maps feature or a specific Maps application feature that can be used for the same. Yeah.
That's great.
And as the next feature, what we did is some user-friendly registration via CSV upload. So, location hierarchies, and I will just to demo this. Okay. So frequently when organizations start using Avni, they are in need to migrate their beneficiaries in a different application or from Google Sheets to Avni. And some of the organizations have multiple location hierarchies. Here, if we see in this organization Ecom, they basically, one of their use case I think is programs catering to children, and the child can be in a village or in the ICDS. So the address of the child can be anything. So in such cases, registering the children or registering the individuals via CSV was more error prone or were not user friendly. So these kinds of options where currently it shows two location hierarchies. Actually, this is locations. So I will move to individual registration. Yeah. So here, currently when I'm clicking individual registration, it shows us two options and we can select the hierarchy in which the child needs to be enrolled. So before this was not there, and hence when someone say, when we download the sample file as well, so it will show the location hierarchy that has been selected. Yeah, so here we have selected state, district, block, panchayat, and in the CSV as well, it shows the same state, district, block, panchayat, and village. To make it easy for users to upload the data and to easily figure out what should be the column names. Yeah. Yeah, so this is regarding this feature. And then the next feature we wanted to show was yeah. So there was, as I mentioned, this RWB organization who has mentioned that to make it evident to users to figure out what needs to be done soon after they log in or once the sync is complete. So for that, we actually brainstormed on different approaches, and we figured out based on the feedback from the client and the UX designer that a product tour approach can work better. So a product tour is basically once the user logs in, showing around the app on the different features that are existing in the app. It need not be specific. Yeah. So basically, based on what workflow you want the users to follow, it can be used to showcase the user on the workflow that the user needs to follow. So it would be something like this, where the tooltips, where the register button is for this user, for this organization, the first action that needs to be performed is registering someone. So that is why here the tooltip says start entering your data by tapping on registering button below, and the register button is highlighted. So it need not be just one thing. Here, for example, if we see this is in a web application, so similarly it can be done in the mobile app application. Just wanted to show how it works. So here they generally show the introduction on something on highlighting some feature on how it works. So next, some other button or a report card can be highlighted, or an icon can be highlighted to show the next one. And then after everything is done, it will get done. So finish button will come where, and the user can stop the tour at any time by clicking on this cross icon. So just wanted to receive inputs from anyone who has used Avni or piloted with the users. or even in general who are planning to willing to use Avni. So do you think it will benefit your users?
So this is basically, did I understand this taking a tour sort of thing is like when you first update your iPhone, it shows you all the different features. Is that what this is?
Yes, yes. Yes, Devanshi. The purpose is the same. I think in iPhone also it would have been similar. The tour is the way they show the tour is different across different application, but the purpose is the same. In some apps or phones, they just show full size screens on what all features are available. So here we were thinking, since it's a single app, just highlighting the different icons because the users might not be very tech no, what to say the awareness of using the different apps might not be there, so we were thinking of highlighting to be more specific.
No,
Yeah.
I think I can see where it's beneficial for sure. Because no matter how many times you teach somebody, hearing it again on the app and understanding where each button is helpful.
Sure, Devanshi. Yeah. Okay. Okay, so these are the features that we wanted to showcase. Any inputs or questions so far? Yeah. So if there is nothing else, then over to you, Anjali.
Sure. Thanks, Maha. Thank you so much. Just on the time, we are at 4. If there are no more questions, then we will wrap up for the day. Yeah, any questions from anyone on any topic, be it on the product side or related to the feature talk that Devanshi did, or for the ecosystem? Any questions from anyone? Okay, then thank you so much, everyone, for joining today. Thank you, PHRII team, Devanshi, for sharing the insights. Thank you for your time. We will plan more such feature talks on different topics with different NGOs. We hope to see more and more participants in the coming community meetups as well. Thank you so much for your time, everyone. Thank you.
Thank you.
Thanks. Bye. Bye, everyone.
Bye-bye.
Thank you. Bye-bye.